Okay, great. Good afternoon, everyone, both to those who are here with us here at Sick Kids, and I know we have a lot of sites joining us from across the country, so welcome to everyone. We are really pleased today to have Dr. Stremler, who is a nurse scientist whose research is aimed at improving sleep and related health outcomes in infants, children, and parents through pregnancy and beyond. She's an associate professor and director, PhD program at the University of Toronto in the Lawrence S. Bloomberg Faculty of Nursing, and adjunct scientist at the Hospital for Sick Children. Her past clinical care activities include staff nurse positions in various maternal and newborn care and sleep clinic settings. In 2011, the Canadian Sleep Society honored Dr. Stremler with its Roger Broughton Young Investigator Award. Dr. Stremler holds an Early Researcher Award from the Ontario Ministry of Research and Innovation. Today, her presentation will address factors affecting infant sleep interventions, and related health outcomes. Results from interventional and observational studies will be presented to facilitate discussion of influences on infant sleep, including maternal sleep behaviors and cognitions, maternal depressive symptomology, and infant sleep location. So welcome, Dr. Stremler. I'll leave the questions on here, so I'll leave these up here. All right. Do you need them?
Good afternoon, everyone. It's great to be here. And I know that you're able to input questions, and I welcome that. So please don't hesitate. I'm happy to take those questions as we go along. So I just wanted to outline for you what we'll try to get to. I have a lot of slides, but we'll see kind of where the discussion and questions lead us, as well as the things that I have here. So we'll talk a little bit about the importance of sleep. I'm not going to go in great detail about that because I'm sort of assuming I'm preaching to the choir here, that we all buy into the importance of sleep. I wanted to talk about the relationship between infant and parent sleep, because although the focus, of course, is on infant sleep, it's really hard for me to talk about infant sleep without talking about parent sleep. And I'll tell you a bit about the research approaches that I take to studying sleep, because I use both objective and subjective measures of sleep. And then we'll delve into some of the studies that I've conducted, some RCTs looking at can we prevent infant and maternal sleep problems, and then some observational cohort work looking at sleep through pregnancy and into the postpartum. And if we have time, I can tell you a bit about some planned projects and an RCT that's going on right now for toddlers and older children who have sleep problems. Is there yeah, or I can just use the mouse. Perfect. Okay. So why do we care about sleep? What's wrong with missing out on a bit of sleep? Well, we know, particularly from the adult literature, that sleep loss is associated with a host of negative health outcomes. So over and over, studies have shown links between sleep loss and poor mental health outcomes. So that's emotional difficulties. That might be increased rates of anxiety, depression. Even population studies have shown that those who are chronically short sleepers have increased risk of suicidality. And also behavioral difficulties. And so especially for children, this is an issue. We see problems with attention, conduct, self-regulation with decreased sleep amounts. Of course, we know your brain just doesn't function as well if it doesn't have the sleep that it needs. So we can see that really easily experimentally. If you deprive people of sleep, this is not the kind of sleep research that I do, but I do have sleep colleagues who take people into sleep labs and deny them sleep and then have them perform cognitive tests, memory tests, learning tests, post-sleep restriction, and we see declines in performance on those tests. So this is crucial for infants and toddlers to think about this piece. They're starting to grow a body of evidence looking at the effects of naps and length of sleep on infant outcomes related to learning and memory and other developmental milestones. It's really in its infancy, but that is given what the importance of cognitive development in the early years. This, of course, is a big issue. And then in terms of daytime outcomes, we know increased fatigue and daytime sleepiness are issues if you are a short sleeper. And more, there are physical health outcomes, evidence growing in that area as well. So cardiometabolic outcomes such as hypertension, overweight, and obesity, and impaired immune function as well. Again, these are experimental studies where adults have been sleep restricted, exposed to common viruses, and we see increased uptake of common illnesses in people who are sleep restricted, and increased inflammatory markers even after one night of sleep deprivation. And then from a more social perspective, we know that there's increased risk-taking behavior amongst adolescents and adults who report consistently sleeping shorter. So associations with drug and alcohol use, cigarette smoking, unsafe sex even, and accidental injury, including motor vehicle accidents. So let's talk about infant and parent sleep though. And as I said, it's really hard for me to think of one without the other. As a nurse who worked with families in pregnancy and in the postpartum, that's really what got me into looking at sleep. I was really struck even in the early postpartum how profound the effects of sleep deprivation were for families, even in the early days. And when I went to the literature to see what strategies or interventions I could offer families, there really wasn't an evidence base there. And so that really directed me in my research career to take a look at these outcomes. And so a model that's been useful for me to think about sleep is the transactional model of infant sleep and parenting. And that's Avi Sadeh and Tom Anders' work. And this is what the model looks like. And you can see that it takes into account the many factors that affect sleep for families. So there are cultural influences, social influences, of course your geographic environment, physical environment may have an influence on sleep. And then there's the parenting piece. So what's going on with the parents? Are there mental health issues? How do they think about their own sleep as well as their infant's sleep? And then there's that little individual, the infant themselves. What's their temperament like? What's their health state like? And how do those pieces interact? So we need to think about things like attachment, emotional availability of the parent around bedtime. What are the interactions that occur with the infant around sleep? And then, of course, what is the infant's sleep like? So what are the patterns, the regularity, number of wakenings, that kind of thing. So for my research, I've really tried to focus on characterizing sleep, taking a look at the factors that influence sleep. And I try and do that using both qualitative and quantitative approaches. Tried to design interventions focused on behavioral strategies and educational interventions. Also moving a bit more towards mobile health and internet interventions, knowing that there aren't that many clinicians trained specifically in sleep. And I kind of like gadgets, and fortunately, there's a growing number of technologies that we can use to measure sleep. So some are more old school. Actigraphy has been around for at least 20 years, and I'll talk more about what that is, but it's a way to measure sleep objectively. And we're moving into an age where wearable devices are becoming much more common, and so I'll talk a bit about how that might influence our ability to study infant and parent sleep on a very large scale that we haven't yet been able to do. So, polysomnography is really the gold standard for objectively measuring sleep, but it's not that practical for infant and parent sleep. Really bringing someone into the sleep lab does not replicate the home environment, and so for most infant sleep research, if you want an objective measure, you're going to use actigraphy. And so an actigraph is a wristwatch-like device. It has an accelerometer inside that detects motion. So this is the same technology that you now have in your Fitbit that tracks the number of steps that you take. But these are research-grade devices. And you get minute-by-minute sleep versus wake determinations. So the movement activity is collected. There's a microprocessor chip in the actigraph as well. So you can collect those movement data over days or weeks if you want. And then we bring the actigraphs back into our lab, download the data, and we have computer programs that run algorithms on the data that allow us to determine for each minute whether the baby or the mom or dad or whoever is wearing the device was asleep versus awake. So we know that movement does occur during sleep, but the algorithm takes that into account. So it looks back at the last 4 minutes, ahead at the next 2 minutes, and makes a determination based on how much movement was going on, whether the person was asleep versus awake. And so then we can calculate number of minutes of sleep, the number of awakenings that occurred, what the longest stretches of sleep were, and we know that's important for being able to go through all the required lighter and deeper stages of sleep and REM sleep. So these are really important outcomes for us to be able to report, and it really overcomes the bias that's introduced by asking parents to report. So particularly with families in the newborn period who are very sleep deprived, you know, it's burdensome, number one, to ask families to record really detailed sleep diaries for a long period of time. But we also know from validation studies that parents tend not to know all the awakenings that occur for their infant, and we know that parents end up backfilling diaries and that sort of thing. So actigraphy is a really great way to get an objective measure of sleep. So we do use sleep diaries, and that helps us a bit with our interpretation of actigraphy. And then we're moving more towards wearable sensors, and I'll talk about that a bit more later. But those are the Fitbit-like devices. So as the technologies improve, the cost of those devices is coming down. And there are also some, you know, they're a bit more open access, some of these devices, and so researchers can be a bit more creative with how they use them. So I talked about sort of my entry into the world of infant sleep and really wanting to be able to offer families some evidence-based interventions in the early postpartum. And that's what led to this trial, the TIPS trial. And we began, oh, are you seeing, oh, my title is a little bit cut off there. But really the question was, can we get parents and infants to sleep better? And knowing that there are adverse outcomes to sleep loss, the notion was, can we prevent infant sleep problems before they occur. And I think it's really important to note that these are not sleep training interventions, that I was coming at this from a prevention rather than a treatment perspective. And that really too came from my work here at the sleep clinic at Sick Kids, and my work with other sleep clinicians who really believe that sleep training shouldn't occur before 6 months of age in infants. So when I was looking into what had been done, it was really with a focus on how can we shape infants' sleep rather than intervene with methods that you might be familiar with, like crying it out and that kind of thing.
Robyn, I'm just wondering if you can define how you're using the term sleep training.
Sure.
Because I think it might mean different things to
yeah,
different audiences.
Sure. Yeah, so for me, when I say sleep training, I'm thinking of approaches where you're trying to decrease the amount of time it takes for the infant to fall asleep, decrease the number of night wakings that occur. Those are usually the parent aims, certainly. And the methods to get that to happen would involve typically extinction or graduated extinction, which would be reducing the amount of interaction with the infant, and also increasing the amount of time to respond to the infant. So some people call that controlled crying, you know, or the cry it out or Ferber method, that kind of thing. Yeah, is that okay? Yeah. So I really wanted to set that sleep training piece aside and focus on what were strategies that families could introduce that might help to shape sleep behavior, that might help promote infant self-soothing. And for me, I really couldn't look at shaping infant sleep without also looking at what could moms do to help with their own sleep. And really just from clinical experience, that came from, you know, talking to women and knowing that they would say, well, you know, the baby wakes up, I feed the baby, change the diaper, do whatever needs to be done, put the infant down to sleep, but then I'm looking at the clock knowing I only have X number of minutes before the baby's awake again. And I, you know, my mind is going, I can't fall asleep, and I know I have a limited time to sleep. So knowing that there was probably also a place to intervene in terms of maternal sleep. So at the time when we looked in the literature, there were only 5 RCTs that had focused on prevention of infant sleep issues in the early postpartum. And, you know, there was some suggestion that there could be strategies that would be effective. These were all quite small sample sizes. They didn't include interventions that looked at maternal sleep, so that was the gap I wanted to fill. They hadn't looked at important maternal outcomes. So for me, you may be only intervening with infant sleep, but really important to look at what are the effects on maternal outcomes if you are changing infant sleep. None of them used objective measures of sleep, so they were all diary maternal report of infant sleep. And most of the studies had a mix of first-time moms and moms having subsequent children. And that too, we know from studies of maternal sleep in the postpartum, that there is a difference between the sleep experience of first-time moms and second-time moms, whether that's you're just more savvy with strategies or less affected by the sleep loss. There are differences there. So we did a pilot study first. So we randomized 30 women, and measured their sleep when the infant was 6 weeks old, so measured maternal and infant sleep. The intervention was delivered in hospital, and I'll delve in a bit more to what that was when we talk about the full-scale trial. And we found that the women who received the intervention slept almost an hour longer at night. The infants woke less frequently and had their longest stretch of sleep at night was 46 minutes longer in the intervention group. So we were pretty excited by those data and applied to CIHR and received funding to do the large-scale trial. So I had some people say, well, do you really need to do the full-scale trial because you found a difference in the pilot? But we really didn't think there would be uptake of the intervention with such a small-scale trial. I really wanted to look at infant sleep at 12 weeks when we know the circadian rhythm is starting to kick in a little bit for infants. So I wanted to see what the difference was at that time point. And really, I wanted evidence so that if the intervention was effective, that it could be implemented in the Canadian healthcare system. That is, we could train nurses to deliver the intervention and it could become part of standard postpartum care. And I really felt we needed to do a full trial to achieve that. So our primary research question was, what is the effect of this intervention delivered by a nurse in the immediate postpartum, that is in hospital, on maternal sleep at night? And we defined that from 9 p.m. to 9 a.m. at 6 weeks and 12 weeks postpartum. Our secondary outcome was, what's the infant's longest stretch of sleep at night? And then we also wanted to know what were the effects of the intervention on the number of awakenings that moms had, the number of awakenings babies had. We had a measure of maternal sleep disturbance. That was a subjective report. We used the Edinburgh Postnatal Depression Scale to look at maternal depression. We had a fatigue scale, and we asked women whether they were exclusively breastfeeding or not at 12 weeks. Yeah, of course.
Sorry, Robyn. I'm just wondering, when I look at that list, how much of what you were looking at was in line with the MCAS material by Catherine Barnard, because that's getting used quite extensively now in Ontario.
Right.
I just don't know if it addresses the sleep issues or not.
If these outcomes address the sleep issues. Yeah, I think I've become, my work has become more aligned with, the transactional model that I put up earlier. Yeah, I think I might have done things a little bit differently. I think I might have added some other, not necessarily outcomes, but I might have asked more questions. This was sort of early days for me, and I struggled a bit with, the RCT committee at CIHR likes things to be quite tidy and tight, and so I struggled with how many outcomes to have and what to include. Yeah, and I think I have more appreciation now of the influence of maternal cognitions around infant sleep. And so my work is moving in that direction a bit more, which I think aligns more with what you're talking about in terms of MCAS. Yeah, so yeah, I appreciate the question, yeah. So we only enrolled first-time moms in the TIPS trial, and they needed to be healthy with a healthy term singleton infant. We excluded women that were taking any meds that might affect sleep. If either parent had a sleep disorder, because we know that partners affect each other's sleep. Didn't want anyone working night shifts over the 12 weeks that we were studying them, and required English for completion of the diary and the questionnaires. And we were delivering a kind of booster by telephone, so people needed to have phone access. So we had women, we assessed them for eligibility and got their consent in hospital quite soon after delivery, and that actually worked quite well. We had great buy-in from, at the time, Women's College Hospital and St. Mike's here in Toronto were our sites. We got baseline data on the women and infants and then randomized right away. If women were assigned to the experimental group, then they had a nurse come and meet with them in their hospital room and deliver the intervention. They received a booklet that summarized the details of what the nurse and the mom had talked about. And then there were phone calls at 1, 2, and 4 weeks. For the experimental group, that was to address any issues that had come up, to reinforce the information that had been given during the intervention. For the control group, that was an attempt to minimize any bias introduced just by having someone call you and interact with you. So there were no sleep issues addressed, and the people delivering the control group calls didn't have any specific training in sleep, whereas we had had our nurses delivering the intervention undergo an 8-hour training program. And then we measured outcomes at 6 and 12 weeks, and we went to the families to do that. So we did home visits for all those moms and set them up with actigraphy on a Monday, and then went back to visit them on a Friday to pick up our actigraphy equipment, and then repeated that at 12 weeks. So what did we talk about in the intervention? So there's an education piece that we thought was really important, just letting moms know what to expect from their infant's sleep in the first couple of months. So we told them about the cycles of sleep that newborns go through, that they do have brief awakenings even within stretches of sleep, and that that was normal. We talked about strategies to let the baby settle on their own, and that was really just letting them know that every little coo or sound that came from the baby didn't need an immediate active response from the parent, that they needed to give the infant a chance just to see if this was one of those brief awakenings and that they might go back to sleep on their own. We talked about crying, and that had really come from the pilot work. That piece wasn't in the pilot intervention, but the intersection of crying and sleep is a challenging one for parents. So we wanted to help them interpret crying a little bit, let them know that that may be kind of a last sign that an infant needs to be put down to see if they can go to sleep, and also that crying is communication, that is their only strategy of communication, and so that crying can mean a number of different things, and that it's not a negative thing that's happening. We talked about infants being quite active in their sleep, that it's not that they're restless in their sleep per se, but that they do a lot of facial movements and grunting and that kind of thing. We talked about swaddling as a strategy if the baby was startling themselves awake. And then there was information about the intersection of feeding and sleep, and that's another really challenging area for parents, particularly in the first 12 weeks, where in our sample, the large majority of women were breastfeeding, so trying to establish breastfeeding, trying to balance the information around frequent feeding and how that intersected with sleep. Then we also really wanted to give some information about really circadian rhythms and how that gets developed over the first few months. And so our recommendations were to avoid bright light at night. And this is important for infants and the moms as well. So, just simple strategies like Do you have night lights or low-level lighting that you can use at night for feeds or diaper changes? So we talked about how exposure to bright light decreases melatonin and that is alerting. And we also talked about the importance of daylight early in the day because that helps to regulate night and wake cycling. We talked to you about social cues that influence the circadian rhythm. So, you know, trying to decrease bouncy, exciting play at nighttime and making sure that social interaction and engagement with the infant particularly happen during the day. And we introduced the idea that you could begin a positive, engaging, short at this point in the infant's life, bedtime routine. So whatever the mom thought she would find rewarding, whether that was, you know, a song and a cuddle or a book, but something that began to institute a sort of regularity to the evening. And we really tried to be sensitive to families' choices around sleep location, infant feeding methods. So none of the advice that we gave was directive around those choices. And we really offered the tips as sort of a buffet that families could choose from. You know, we encourage people to try things out and to use the tips that worked for them. Tips that were focused directly at maternal sleep were what we call sleep hygiene. These are kind of the classic things that we should all be doing for our sleep. So making it a priority, keeping your bedroom cool, dark, and quiet. You know, exercise we know during the day is helpful for sleep at night, limiting caffeine and alcohol, those kinds of things. And then we really addressed the challenge of sleep deprivation in the postpartum period. So, you know, acknowledging that it's difficult to miss out on sleep and to kind of be gentle with yourself around that. So to ask for help, to accept help, and to try and limit visitors and demands on yourself in the first few weeks. We also did a little bit of training with the moms on 2 relaxation strategies. So a deep breathing technique and also progressive muscle relaxation. And we suggested that they could use those techniques in the times when they wanted to go to sleep, had the opportunity to sleep, but were having trouble winding down. And we also encouraged women to give themselves permission to go to sleep early. If they were tired, the infant was down, maybe it was 8 o'clock at night, but if they were okay to go to sleep then they should do that. Or if they were more of a night owl, to go back to bed after the 6 a.m. feed to kind of stretch out the opportunities they had to sleep. So we randomized 246 women. Everyone received the intervention who was supposed to. And then we had really good rates of follow-up at 6 and 12 weeks of postpartum. So, you know, between 85 and almost 90% follow-up. So these are the characteristics of the women that were in the trial. So 32 years on average age. They were full term. Predominantly Caucasian, but you know, about 35% combination of other backgrounds. Large majority, though, in stable relationships and university educated. So this is a higher socioeconomic status group. Yeah.
What's one of the criteria as well was that they did have a partner?
No, being partnered was not a requirement. Partners were welcome to join the intervention session if they wished to, but no, women did not need to have a partner. And, we included St. Michael's Hospital in Toronto specifically to try and have a bit more of a diverse sample, especially in terms of socioeconomic status. But as we know, these are the kinds of families that tend to enroll in research studies. So, yeah. So here are the data for maternal nighttime sleep. So this is in minutes. And you can see there are not big differences, not statistically significant differences between the sleep intervention group and the usual care group at either 6 weeks or 12 weeks. So at 6 weeks, women were getting about 6.5 hours of sleep. And then at 12 weeks, they were getting about 7.5 hours of sleep. This is our secondary outcome, length of the longest stretch of infant sleep at night. And again, not big differences there between the groups, increasing as we would expect from 6 weeks to 12 weeks. And we found no other statistically significant differences in either maternal awakenings. Sorry, I don't know what's gone wrong with my formatting there. Infant awakenings, maternal report of sleep disturbance or fatigue or depressive symptoms. And I think what you can't see there is exclusivity of breastfeeding. So in terms of breastfeeding, I was actually quite happy with that outcome. We found no difference, and that had been a critique or a concern of some reviewers and other clinicians. If we were introducing these ideas around shaping infant sleep, would we be affecting breastfeeding in a negative way? Would it mean that moms were feeding less, perhaps, and that might interfere with the establishment of breastfeeding? So although I was quite disappointed in the other findings, I was quite happy to see that we didn't find a difference in exclusivity of breastfeeding. You had a question?
In the previous slide,
Yeah.
So the mothers who received usual care actually slept more?
So this is, so this is the length of the longest stretch of sleep for infants. I mean, yes, if you just look at the means, it's, what is that, 12 minutes more, but it was not a statistically significant difference. We asked women how much they accessed resources, and lots of them did. There's a big business in books about sleep, so lots of women had access to book, at least one book. But the next most common resource was other mothers, and if any of you have spent any time hanging out in mums groups or playgrounds, you'll know that sleep is a big topic. There's a lot of time dedicated to talking about your infant's sleep. And then the internet was another big source of information. I think it's fascinating to see how few talked to their care providers about sleep. You know, it's interesting. I don't have the data here either, but I haven't presented the data, but we do have data. We asked women how many of them asked their healthcare professionals, but we also asked, did your care providers ask you about your sleep or your infant's sleep, and the rates are similarly low. So I think this is, you know, an area where we really have to focus more attention. I know from some work that I've done that entry-level healthcare professional programs have very little content time spent on sleep, period, and even smaller amount on pediatric sleep or infant sleep. So we need to do something about that. So I think that's contributing to families aren't asking about sleep, care providers aren't asking either. We asked women what they liked about being in the study. Women appreciated getting written information, meeting with the nurse and talking to her about sleep. Even keeping a sleep diary was more enjoyable than we had anticipated. And almost everyone said they would participate in the study again. So for me, there was really a period of mourning when we didn't find differences between our groups, but, you know, kind of try and regroup after something like that and think about, well, what can we do with this information? We know women appreciated getting the information about sleep. They weren't getting it from reliable evidence-based sources elsewhere. And women reported using many of the strategies. So it may be that we didn't measure far enough out. We may have seen differences later on beyond 12 weeks. It may be that this was a very savvy population, that the sample we had was quite educated. When we initially designed the pilot study, there really wasn't as much talk about sleep. And since then, there's really been an explosion of interest and I guess resources online and in the community. So it may be that they were able to, those in the control group were able to access some of the advice. But we concluded that, given there were no differences, this was not something that we could recommend being built into standard postpartum care in hospital.
Couple of questions.
Yeah.
If that's all right.
Yeah, of course.
What about sleep aids? Herbal teas, the lemon flowers, or alternative therapies like yoga, exercise, and meditation? Would you recommend something?
Yeah, so we did, we did talk to moms about what worked for them with their sleep prior to pregnancy and the postpartum. And so, we talked about things like yoga, meditation, that if those were helpful to moms, they could certainly continue those, or if they had an interest in taking those up in the postpartum, that would, supplement the progressive muscle relaxation and the deep breathing techniques that we had recommended. There isn't a good evidence base around herbal preparations, and so we didn't recommend that. We did have a couple of moms ask us about melatonin, but the evidence around melatonin supports its use for jet lag. The postpartum, I guess you could look at it as a really prolonged case of jet lag, but we did not advise for use of melatonin. Yeah. Okay. So also shortly after the TIPS trial was published, there was some evidence that came out that some similar interventions might be effective in higher risk groups. And so that may be part of the issue with not finding a difference in this group, that the women were actually getting a fair amount of sleep anyways, and so that the intervention may need to be targeted at those who are more sleep deprived and at higher risk socially. And so Rachel Mamber is at Stanford, and she's using the TIPS intervention with group of women who are predominantly unpartnered and at higher social risk. So we're looking forward to her findings. Yeah.
And how did you know for sure that some of your participants weren't letting babies cry out?
We asked about what strategies they used. You know, at the time, there really wasn't the focus on that kind of sleep training that early. So this would have been in 2009. And there was a lot of talk about the Baby Wise program in the US, which is one of those approaches that recommends starting those kinds of interventions much earlier. And at the time, my colleagues and I didn't really think that it was an issue in the Canadian context. I think now it's become much more common. There really weren't that many sleep consultants at the time either, so there weren't really, I would say, there weren't resources available at the time recommending those approaches. So it really wasn't on our radar at that time. I think now that would be an important thing to ask about. Yeah. Yeah. So I can't say for sure.
Yeah.
Because we didn't ask the questions that way. Yeah.
If the moms were feeling overwhelmed, did you ask them that? And did they have access to a counselor or someone? We recently had Linda Gilkerson come in from the Fussy Baby Network in the US, which does a lot of just counseling with families, really trying to understand, you know, what they're experiencing with their baby, and coaching them.
Right. Yeah. So the phone calls at 1, 2, and 4 weeks would have gotten at those issues. So if there were difficulties
but in the moment, if a parent was in trouble, she had no one to call.
No, we didn't have the intervention set up that it wasn't that we said do not call. They had, it wasn't presented to the moms that way. It was presented, we will call you at 1, 2, and 4 weeks. But those issues may have come up, and we certainly had our nurses trained that, you know, if there were concerns about depression or coping, you know, they sort of had a protocol to follow to make sure the woman got whatever assistance she needed. Yeah. Same for breastfeeding. You know, if it seemed at the phone calls that things weren't going well, they had resources they could direct the moms to for that as well.
Just another sort of comment up from online. I'm thinking whether other factors such as level of preparedness for the motherhood and how strong the family support is could contribute to the mother's sleep as well.
Yeah, so we did examine using the multidimensional scale of perceived support, how much support the moms said they had, and didn't see any differences across groups. So I don't know that, and it was overwhelmingly high support, which probably aligns with the higher education and higher socioeconomic status. But I think that is why it's really important to test the intervention in a high risk group, because I think that that may come into play there. Yeah. So I think we've kind of talked about this. Yeah. So if you're interested, the paper was published in the British Medical Journal So you can check it out there. I also have the booklet that we use that moms received. It's available on my website, which I should have put the URL there, but it's www.stremlerresearch.com. Or you can email me and I can send you a copy. So we wanted to look at a couple of different things from the TIPS trial, and wanted to look at infant sleep location. So where were the babies sleeping? This is a controversial issue. It's a difficult decision for families. It's something that families struggle with, and the people around parents have a lot of opinions on that. Healthcare professionals, of course, have statements on that. So the Canadian Pediatric Society has a very clear statement around the infant sleeping in the same room as the parents, but on a separate sleep surface. But we wanted to find out what were parents planning to do, and then what did they actually do. And so we defined bed sharing as having the infant with them in the same bed that they were sleeping in. Room sharing was the infant in the same room, but in a separate bed, a separate sleep surface. And then we called solitary sleeping being having the infant in a separate room on a separate sleep surface. So we looked at the data from the RCT. As part of the intervention, we didn't give any information about infant sleep location. We let families do what they were going to do. If families asked us about infant sleep location, we let them know what the Canadian Pediatric Society recommendations were, but we left it at that. And because we didn't have any difference in the RCT outcomes, we aggregated the data to perform this secondary analysis. So how did we get at these questions? We asked moms in the immediate postpartum what they planned to do in terms of infant sleep location. Did they plan on bed sharing or room sharing? We asked them what their plans for infant feeding were, because this is part of the controversy around infant sleep location. There are some who will say that bed sharing promotes breastfeeding, and so we really wanted to know what were mom's plans for feeding. And then, of course, we had our data that we gathered as part of the trial related to objective sleep. But in the diary, we also asked at 6 and 12 weeks where the infant was sleeping that night. So we had 4 nights of reporting where the infant had slept. And we also asked, where did your infant usually sleep in our exit questionnaire, asked about sleep disturbance, breastfeeding exclusivity, and depression rates. So there's one limitation in that we didn't specifically ask, excuse me, about plans for solitary sleeping. So we asked if you were bed sharing or room sharing, and we've kind of made the assumption that if you said you weren't bed sharing and you weren't room sharing, that the infant was solitary sleeping. Because of that, we had a few cases that we couldn't reliably classify as one or the other. So you've seen this, the participant characteristics. So this is in the immediate postpartum when we asked, what are your plans? And so the large majority were following the Canadian Pediatric Society recommendations, or planned to follow those. So 65% saying they were going to room share. The next most common group was about 21% saying they were going to do a combination of bed sharing and room sharing. Much smaller percentage saying that they were going to bed share. They were committed to that, about 5%, and about 6% that were assuming had planned immediately to have the infant solitary sleeping because they had said they were neither bed sharing nor room sharing. In terms of infant feeding, you know, reflective of Toronto's high rates of exclusive breastfeeding. That was overwhelmingly the plan for families. And then here's what actually happened. And we know that these decisions, you know, you can plan, but then there's real life that occurs. And so you can see that there are many more families that were bed sharing than had planned to do so. So it's almost 17% at 6 weeks, declining a bit at 12 weeks to 12%, and not as many predominantly room sharing as expected, and more solitary sleeping than had originally been planned for. So this slide is based on the usual arrangements, but we also had the daily data, and so we were able to look at any bed sharing across those times, and you can see it goes up significantly. So at 6 weeks, basically half of moms have done bed sharing at some point over the 4 days that we were studying their sleep. Again, declines a bit at 12 weeks. So then we were interested, because again, there's a lot of debate about, do mums sleep better if the baby is in the bed with them or not? So we wanted to take a look at how does infant sleep location affect mums' sleep. So you can see the 2 lines that I have bolded there. We saw differences in terms of the number of minutes of sleep and the number of awakenings that mums experienced, with longer stretches of sleep for the women who were either room sharing or had their baby in a separate room, and more awakenings for the mums who had the infant in the bed with them.
And was that sleeping recorded in their diary, or was that
No,
a device that you got?
this is objective measures of sleep. This is on actigraphy. So it's from our devices. Yeah. So this is pretty reliable data. And to my knowledge, this is you know, the only study of this scale to actually look at this. So there's a lot of opinions out there, but I think this is really one of the only studies that has objective data looking at this. We didn't see any differences, though, in terms of infant sleep, and that's interesting because that's often another argument for bed sharing, that the infant will sleep better. Certainly from an objective perspective, that didn't hold out. We didn't see any differences for infant sleep. We looked at maternal fatigue because we thought, you know, maybe something might be captured there. No differences. No differences in subjective sleep quality either. So that didn't seem to be affected. And I think really importantly, no differences in exclusive breastfeeding. So again, that's such a piece of the infant sleep location debate, but we didn't see any differences across infant sleep location. So those were the 12-week data. Or sorry, the 6-week data, and this is the 12-week data. And that difference that we saw in terms of the number of wakes disappeared, so it wasn't statistically significant anymore. But that longer stretch of sleep has stayed significantly different, except that we see the difference is that those who have the infant in a separate room are getting the longer stretches of sleep. So plans for bed sharing and solitary sleeping aren't uncommon among new mothers, so that's different than the Canadian Pediatric Society recommendations. We see actual rates across the postpartum are quite high. Room sharing is the most common, but those other 2 situations are quite common as well. We see infant sleep location affecting maternal sleep continuity, so how long do you stay asleep, but not affecting infant sleep or breastfeeding. So I think, you know, it's interesting. I think there's quite a value placed on early acquisition of being an independent sleeper. That solitary sleeping condition is more common than I think we've appreciated. And, you know, what you could examine in a larger sample across longer periods of time is, are there relationships across time with that solitary sleeping and exclusive breastfeeding rates, which tend to drop off after 6 months. It's also important to note, I think, that bed sharing was more common and solitary sleeping less common in the non-Caucasian participants, and that's a finding that's been borne out in other studies as well. And I think from a sleep perspective, we have to look at that reactive piece, and that parent responses to infant feeding and challenges around crying or sleeping behaviors likely shapes those infant sleep location decisions. And so that should maybe be part of future sleep interventions. So that paper is in the Open Sleep Journal, if you're interested in taking a look at that one. So this is a recent secondary analysis from the data, so it's not been published yet. We've presented it at a couple of conferences. But I was interested in subjective reports of sleep versus the objective data. We've seen some studies show an association between subjective report of poor sleep quality and depressive symptoms. But the data looking at objective sleep data and postpartum depression, there hasn't been a lot of coming together of those findings. Some have found a relationship, others haven't. But there have been very few studies like ours that had both an objective and a subjective measure. And so this was kind of a unique opportunity to look at those relationships with postpartum depression in a large sample. So why am I interested in that? Well, if maternal appraisals of sleep quality is key to maternal depressive symptoms, then it may be that that's potentially modifiable, that we could intervene and have an effect on depressive symptomatology. So that's what we wanted to look at, subjective sleep quality, objective sleep outcomes, and the relationship to depressive symptoms. So from the TIPS data, we've got the actigraphy. We use the EPDS. The General Sleep Disturbance Scale is a sleep quality measure specifically designed for pregnancy and postpartum. And we also asked moms to tell us, what do you think about your sleep? Is it a problem? If it is it a small problem or a big problem? And then we had our social support measure. So we did logistic regression on those data and did a number of different models looking at what's the risk, the odds of depression according to the different types of ways we measured sleep, objective versus subjective. So at 6 or 12 weeks postpartum, 22% of the sample had a score 12 or higher on the EPDS, so significant depressive symptoms. 8% of women, when we asked, said, yeah, my sleep is a big problem. 35% said it was a small problem. When we looked at their subjective sleep quality at baseline, that wasn't related to depression at either 6 or 12 weeks. When we looked at sleep quality at 6 weeks, though, that was associated with 3 times the odds of depression at either 6 or 12 weeks. If women had reported that their sleep was a small problem, that led to 3 times the odds of depression. If they said it was a big problem, it was associated with more than 8 times the odds of depression.
So can you go back to the slide before?
Yeah.
So more women were experiencing postpartum depression at 6 weeks.
Yes, we at baseline, we didn't have very many women scoring
So
high.
I'm just wondering, who's asking them at 6 weeks? If they're experiencing
Clinically, in the clinical setting?
Because I'm thinking no one.
Well, I mean,
Because usually you get asked soon after the birth, like within the first few weeks.
yeah.
But not at 6 weeks.
I guess, you know, if you've had a cesarean, typically you're asked to follow up 4 to 6 weeks, I think is still the standard. That's an opportunity. You know, pediatricians, I think, are the ones who are having contact with families.
We don't know if it's actually being asked.
No, we don't. And my colleague, Dr. Cindy Lee Dennis, who's with me at the Faculty of Nursing, has a trial that's going on right now in concert with Target Kids, where that's being built into the visits with the primary care providers for the infant, because, you know, to try and get at this, that this is a natural point of contact for moms with the healthcare system. So if you capitalize on that, will it make a difference in outcomes?
I think it's something, because I'm sure we have a lot of healthy babies, healthy children.
Yes, out there. Yeah. Yeah.
And, you know, the session filled up before we even started.
Yeah.
So I'm just thinking they too are in a good position because they are visiting those families.
Right.
You know, often for several weeks after the baby comes home.
Yes. Yeah.
To again ask and at least encourage the family to reach out to their physician then if they're seeing indicators.
Well, and I think the really interesting piece with these data are, you know, there's stigma around reporting depressive symptoms, and there may not be as much stigma around reporting difficulty with your own sleep. And so if we know that there's this relationship between reporting poor sleep quality and depressive symptoms, that can serve, number one, as a trigger to ask further questions about depression, but number two, maybe a way in, asking about sleep may be a way into talking about depression. So I think this is kind of interesting findings, and I better take my Christmas holidays and write this up and get it out there.
Just another quick question as well, whether or not you asked moms if they had contact with public health as well.
We did, and that would have, we asked if they, not if they had contact, but if they had asked about their sleep. That would have come up in that chart I showed back with the TIPS data. So very few had asked anyone for help with their sleep. So there would have been few asks to public health nurses about sleep, but I can't say right about other contact. Yeah. So I'm just keeping an eye on the time there. All right, we're going to leave the TIPS trial data behind, and I'm going to tell you a little bit about an observational cohort study that we've completed. It's, we called it the Sleep Time Study, and this was funded by CIHR. And really, you know, there's not been a ton of research on sleep during pregnancy and following women into the postpartum. We know pregnancy for a number of reasons, physiological changes, but also psychological stressors. There's lots of reason to miss out on sleep in pregnancy. We know sleep complaints are common in pregnancy, but we've kind of just shrugged our shoulders and said, well, you know, what did you think you were getting into? This is just going to happen. And yet we know sleep disturbance has effects on maternal and infant health. So I really wanted to drill down a bit more into this, because I think that attitude probably limits help seeking by women for sleep loss during pregnancy. Because we don't have a lot of interventions to offer, I think that limits healthcare providers asking about it, because there's nothing worse for a clinician than asking someone about a problem and not having a solution to offer to them. And hence, we haven't really moved anywhere in terms of effective interventions. So, whoops. My main objectives, which is not what I'm going to talk about today, but I wanted to tell you what the overall objectives of the study were. We really wanted to determine what the prevalence of the 3 most common sleep problems in pregnancy were, because we've not had any studies that have looked at sleep problems across the board. They've typically just looked at one sleep problem in a group and a small group of women. So we wanted to determine how common restless leg syndrome, insomnia, and sleep disordered breathing were in a large cohort. We wanted to follow them across time so we could talk about the patterns that occurred, whether problems resolved or when they came up, when they appeared. And we wanted to follow into early postpartum as well to see about resolution of those problems and look at factors that were associated with the problems. So we enrolled women and surveyed them by phone at 4 time points. Because of the size of this cohort, we weren't able to do objective sleep measurements. But we talked to women and on the phone. We did about an hour-long survey with them in the early 2nd trimester, 28 weeks, and 36 weeks, and then at 4 weeks postpartum. So we were looking for women who were pregnant with their first baby. We wanted to enroll them at less than 20 weeks gestation so we could get them in for that first interview. And these are kind of our usual exclusion criteria: taking medications that affect sleep, having a sleep disorder diagnosis already. We felt that anxiety around women who'd experienced recurrent losses would unduly affect sleep, and so we excluded those women. And because one of the things we were interested in tracking for was the development of perinatal health problems, we excluded women who already had hypertension or diabetes or depression or anxiety. Oops. So we enrolled almost 500 women. We enrolled women across Canada because we were doing telephone interviews. We could do that. And our funding allowed us to travel across the country and set up booths at baby shows and recruit women early in pregnancy that way. Oops, I'm going the wrong way. So average age was around 30. Again, a high socioeconomic, highly educated sample. And these are the demographics that we had on the women. You know, we had a whole host of things that we asked them about: their physical health, their psychological health, the social support that they had. I'm not going to show you the whole list of things that we asked them about their sleep. I'm just going to focus on this secondary analysis. And this is the measure of sleep quality that we used. So this is the Pittsburgh Sleep Quality Inventory. It's probably the most commonly used measure of subjective sleep quality. It's been validated in all kinds of different populations. And it gives you a cutoff score. So anyone who scores above 5 on the tool is considered to have poor sleep quality. You also ask about sleep duration and the number of wakes. So these are subjective reports of those that we have. I don't know why I've forgotten how to use the. So we also asked about maternal cognitions around infant sleep. So this is a tool that offers a number of statements about infant sleep, and the mom responds to those. So there are subscales related to doubt, anger, and limit setting. So for example, under doubt, it would say, ask the woman to rate how much she agreed with a statement like, I'm confident in my ability to manage my infant's sleep. Under anger, it would say something like, you know, I get angry with the demands that my infant places on me at nighttime. In terms of limit setting, it tries to get at, you know, how long they are willing to leave the infant or respond to the infant. And then we asked about their behaviors related to infant sleep. So we asked how did they settle the infant to try and gauge how actively involved they were in settling. We asked how often they checked on the infant just to check, not because they heard the infant crying and knew they needed to go in and feed, but checking just for the sake of checking. And then we asked our questions about infant sleep location. And again, we used the Edinburgh Postnatal Depression Scale. So we wanted to look at a model thinking about postpartum depression and maternal sleep quality with maternal cognitions and the behaviors around infant sleep. So we hypothesized that the mom's thinking about infant sleep would mediate the relationship between depression and the behaviors she engaged in around sleep with her infant. That those maternal behaviors would mediate the relationship between cognitions and sleep quality, and that both those things would mediate, sorry, it should say postpartum depression down there. So we did path analysis and looked at whether these variables were mediating things. And we controlled for history of depression, either prior to pregnancy or at any of the time points we had measured during pregnancy, and also controlled for age, education level, and social support. So we did find that depressive symptoms predicted more difficulty setting sleep limits, more likely to be associated with anger at the infant's demands related to sleep, and more doubt about their ability to manage their infant's sleep. If women scored high on the doubt scale in terms of cognitions, that was related to increased checking on the infant just to check. Also higher rates of bed sharing. Kind of makes sense, right? If you're not sure what to do. And that mediated the relationship between depression and those behaviors. Having doubt about your ability to manage sleep also predicted poor sleep quality for the mom. And that was through increased checking just to check. So, I mean, if you're checking just to check, you're not asleep. And moms who had anger around the infant's demands were less likely to say that they were just checking. And that anger mediated the relationship between the decreased checking and depression. So, you know, again, you can see this really strong relationship between the sleep quality score and the depression score. So just really highlighting again the importance of that relationship. So, you know, again, it's just further evidence that we need to pay attention to that relationship, but that there are also these targets for possible education for moms around doubt, around infant settling, the checking, issue. And so that those cognitions around infant sleep could also be explored by clinicians.
A quick comment from online, just along the lines of future research. So if this research could be continued, this person's wondering whether a longitudinal study could be designed to compare the sleep for babies who started with SS at an earlier age to those who started SS at a later age. And they believe that SS could cause children lacking sense of safety and security, feeling desperate when no parent comes over to comfort their crying in a dark, solitary room. So thinking a lot about attachment theory.
But we don't actually know that just because they're sleeping in solitary, parents aren't being responsive. Like, I think that's a big assumption that is being made, but I think lots of parents still go, baby may be in a separate room, but it doesn't mean they're saying, I'm never going to go in when I hear the baby crying.
I think this is what the person is getting to as well.
Yeah.
And goes on to say, extended length of sleep for mothers is a short-term gain, but what about the long-term gain for the emotional well-being of the child? I'm sure.
Yeah, I mean, I think those are important things that we don't know about. And the only way to answer those questions is to build those into this kind of study. So infant sleep location. How do you respond to your infant? What kinds of settling behaviors do you enact? So all those things I think would be important to build into a study like this, because you can't answer those questions right now, right? I mean, we don't have those data. I think that's always the concern. We're not talking about sleep training today or, difficulties with sleep problems in infants. I think that's something that we're going to get at more at the study day. We're going to drill into that a lot more. But I think that comes up every time I present on infant sleep. What's the balance between maximizing maternal sleep and yet being responsive to the infant? I think, though, we can't lose sight of the fact that there's a strong link between maternal depression and maternal sleep loss. And so we have to preserve maternal sleep to prevent maternal depression, and knowing what we know about how influential maternal depression is on interaction with infants. So it's a complex set of relationships. Yeah.
Thank you so much.
Thank you.
Was so informative.
Just another comment on that same thread. So if a parent responds to baby's crying, how do we understand the data that parents have longer sleep and less wakes and less baby wakes, and the frequency of crying would be recorded?
Well, I guess I can speak to the parents having fewer wakes doesn't mean that they're ignoring the infant. So,
those small disturbances where you might wake and sort of startle a little bit, but goes back to sleep fairly quickly. Then if the baby's in a separate room, then the parent isn't aware of those.
Right. Yeah. And that's a very normal piece of sleep. I mean, as adults who consider themselves good sleepers do have brief awakenings, brief arousals all the time. I mean, that's probably an evolutionary throwback, right? When we had to worry about saber-toothed tigers coming in the middle of the night, there was a good reason to have a brief arousal, check your environment, and if you're okay, go back to sleep. So I think our brains are hardwired to do that. And for infants, that happens as well. So I don't think we have any evidence that those wakenings, those brief arousals, that interacting with a parent in that brief situation has an effect on any sort of attachment outcome. Or you know, there's a paper that I think I'm going to recommend for the study day that looked at sleep training and then looked at attachment at 12 months and didn't find any differences. Yeah, Michael Gratis. It was a small sample, but it's the best evidence that we have out there.
But there's a lot of research around regulation that shows that parents who respond to their babies consistently and appropriately are able to regulate better earlier.
Yeah, I mean, it's, you know, sleep is important, but it's also a small piece of what parents do, right? So, I mean, that's the beauty of a randomized control trial for these kinds of interventions, because presumably the high responders and the low responders are equally distributed across the groups, because there are just so many factors that you can't control for. So the best way to control for them is to randomly assign people to those interventions. Try and sort that out as much as we can. Complicated, but I have no shortage of research questions, which is good news for me. Yeah.
Lots of opportunity.
Yeah.
Thank you.
Thank you. My pleasure.
If you could pop up and just say a few words about the study. Yeah, I was going to. So for the audience online and those who are here with us today, Robyn's made references to Study Day. So Study Day is happening February 13th. And it is something that is it's somewhat contained in terms of who's been invited and who's attending, and Robyn will be with us for that day, and we'll be looking and reviewing a number of articles around sleep and identifying whether there are some messages that we can share with clinicians, with practitioners, Healthy Babies, Healthy Children, other programs in other provinces, so that we can get some consistent messaging out to parents as they struggle with issues around sleep and sleep patterns. So that will happen, and hopefully there will be something released as a result or produced as a result of that day, some kind of a tip sheet or resource. You know, we really don't know until we get into the day. And then in the spring, we're doing a rounds presentation on the mental health of 3 to 6 year olds, and we will have a corresponding study day that will look at that topic as well. So we're approaching rounds a little differently. We're not doing them every month anymore. We're doing them once every 3 months, and it's a much more intensive. We have a speaker, and then we follow up with a study day and have representatives from communities where we've been working quite closely with certain communities across the country. They're invited to attend and spend the day with us to explore those articles.